There are several types of overuse injuries. The few that we're going to talk about today are carpal tunnel, tendonitis, elbow epicondylitis, also known as golfer's or tennis elbow, stress fractures, and plantar fasciitis. Carpal tunnel is a nerve injury. There's a big nerve in the wrist that gets trapped when we overuse the wrist too much. In sports medicine, where we commonly see this is in cyclists, wheelchair athletes, and even musicians because of the repetitive overuse of the wrist. And as a result, that nerve, otherwise known as the median nerve, it gets compressed. And what happens is it decreases the sensitivity and strength in your thumb, index, and middle finger, and part of your ring finger. So a lot of people come to us complaining of dropping things, or numbness and a painful tingling in their hand, particularly at night, and just an overall inability to perform their daily activities. Oftentimes we diagnose carpal tunnel syndrome first with x-rays to make sure there's not some kind of a bony issue compressing the nerve or causing similar symptoms. The confirmatory test for carpal tunnel, however, is a nerve conduction study, or an EMG. So once that diagnosis is made, there are several treatment options. First, we go very conservative with night splints to immobilize the wrists so that they're not hyperflexed or hyperextended when you sleep at night. We also recommend formal physical therapy just to improve the overall hand, forearm, and elbow mechanics, let alone the strength and pain. And then if that doesn't work, oftentimes we can do an injection, not into the carpal tunnel per se, but into a band of tissue that's pressing on or compressing the median nerve. And finally, of course, if that doesn't work, then we have people go to surgery. Certainly for those people who don't want to have surgery, decreasing or avoiding or limiting the aggravating activities that cause the symptoms can be a form of treatment, and sometimes even over-the-counter anti-inflammatories can help in the short term. A very common overuse injury that we see in the sports medicine clinic is tendonitis. And that's an acute inflammatory response to repetitive trauma to a tendon. We can see that in the bicep tendon, we can see it in the elbow, we can see it in the wrist, we can see it commonly in the patella tendon, and certainly in the Achilles as well. Symptoms of tendonitis include pain, swelling, and stiffness over the tendon. And oftentimes this occurs, as I said before, as a result of just repetitive overuse. Anti-inflammatories can often treat this pretty effectively. Once we hit that 6-week mark after the symptoms have started, we move out of that acute inflammatory state and into something called tendinosis, which is more of a chronic degenerative state of those tendons. So anti-inflammatories, in theory, don't tend to work as well. Remember that tendons attach muscle to bone, and so really the treatment other than rest and anti-inflammatories for acute tendonitis is stopping the offending activity that's caused the pain in the first place. If we progress past that 6-week mark, then we start looking at physical therapy to improve the integrity of the muscle that's attached to the tendon. And we focus on a type of exercise called eccentrics. And that's where we elongate the muscle, but we strengthen it. Eccentric exercises are really the cornerstone of treatment for chronic tendonitis, or as I called it earlier, tendinosis. These terms can also be used interchangeably with the term tendinopathy. Other ways we can treat this is through injections, such as platelet-rich plasma. Sometimes we can dry needle or do prolotherapy or percutaneous needle tenotomy of the tendon. Essentially what that does is it makes it bleed, it causes an acute on chronic inflammatory response and encourages the tendon to heal. If conservative measures like I just mentioned don't work, we start looking at changing the mechanics of how a person got injured in the first place. And certainly if that doesn't work, after about 6 months of conservative treatment, some people actually need to have surgery. What we don't want is for people to immobilize a tendon. That just increases the amount of stiffness and makes a physical therapist's job that much harder when you do go to physical therapy. So the treatment again is rest, stop doing whatever you're doing that caused the injury in the first place, and anti-inflammatories, and certainly go see your doctor. Another common chronic overuse injury is elbow epicondylitis. The common names for lateral and medial epicondylitis are tennis elbow and golfer's elbow. So tennis elbow is lateral epicondylitis, and golfer's elbow is medial epicondylitis. Now, itis implies an acute inflammatory response, but we all know that this can last longer than 6 weeks. Some people present to our office after having years of elbow pain. And interestingly, most people who have tennis elbow don't play tennis, and most people who have golfer's elbow don't golf. But these are repetitive overuse injuries, typically either from hyperextension or hyperflexion of the wrist over and over and over again, and sometimes of the elbow. Oftentimes, as I said, due to this repetitive motion, people have weakness, they have pain, they drop things. Sometimes they'll even have tingling in their forearm and in their hand. Believe it or not, 85% of people get better in 1 year without any treatment at all. So tennis elbow and golfer's elbow actually resolves all by itself if you do nothing but avoid the offending agents for a year. Now, if you can't avoid those types of repetitive activities because it's your job, there are several treatments. We can put you in a splint. Typically we use those at night. There are some injections that we can do, preferably under ultrasound guidance. And certainly for those people who don't respond to conservative treatments like PT as well, we send them for a surgical consultation. Plantar fasciitis is a very common injury that we see in the sports medicine clinic. And really the definition is heel pain. It's worse with the first morning steps. That's the most common complaint, and tends to get better as we walk during the day. The cause of plantar fasciitis is really due to repetitive trauma of that plantar fascia, which is like a strap of leather on the bottom of our foot, and it attaches to the bottom of our heel. And over time, it causes micro tears in the plantar fascia right where it attaches to the heel bone and causes pain. 95% of people with plantar fasciitis get better in 12 to 18 months if they just rest and do conservative treatments. Only about 5% of people need to have surgery for plantar fasciitis. It's extremely rare to have surgery for this. A lot of times we'll use night splints to keep the foot from plantar flexing at night. Sometimes we'll do injections. Some people even use steroid to decrease pain, but there are some risks associated with that. But the mainstay of treatment is physical therapy and support of the foot and the arch. Sometimes people will also use gel cups or shoe inserts just to help cushion the bottom of their foot. The last overuse injury we'll talk about is stress fractures. And stress fracture location really varies by sport. For example, in runners, we see stress fractures most commonly in the navicular, which is a bone in the foot, as well as the tibia, which is the shin bone, and even in the metatarsals, which are also bones of the foot. And stress fractures are really a remodeling response to submaximal force on bones. In other words, the bones haven't been given enough time to heal. We see these injuries mainly when people increase the intensity, frequency, or pace of their training and don't give themselves enough time to recover and adapt to their new training regimen. Those at greatest risk for stress fractures are women, and there are several reasons for that, but also long distance or endurance athletes, We can also develop stress fractures not just in the lower leg and foot, but in the hip. But normally it's in weight-bearing body parts. The treatment for stress fractures is rest. Oftentimes we'll put people in a walking boot, and over time we try to get them back to some weight-bearing activity to encourage that bone turnover and remodeling. The diagnostic tool that we use to confirm a stress fracture is an MRI. That's the gold standard. We usually start with an X-ray, but oftentimes we can't see stress fractures with X-rays. Bone scans are pretty good at locating a hot spot, but they're not very specific in terms of what's actually going on at that spot. So again, an MRI is the gold standard. And once that's confirmed, we have people rest for about 4 to 6 weeks, and then we see how they're doing. And if they're pain-free, then we can start to return them to their activity slowly.